Hello and welcome to this presentation. My name is Henrik Støvring from Aarhus University and Steno Diabetes Center. I'm a professor of statistics and pharmacometrics. In this presentation, I will look at the studies, the trials that has been done within the Bandim Health Project. My interest in this started when I was approached by the Danish newspaper Weekendavisen at the beginning of this year and asked to do an independent assessment of these trials. I was soon very surprised. I found strong claims of effects, but I had a much harder time finding any evidence for these claims, at least not when I looked at the randomized controlled trials, the RCTs. So I decided to look into them and reassess them, and today I'll present some of the results. This is a presentation that is also given at the Danish Society of Theoretical Statistics and Danish Epidemiological Society. They have organized a meeting in Odense where I present this. This work that I present is joint work with Professor Claus Ekström from Copenhagen University, Professor Jesper Schneider from Aarhus University, and Dr. Charlotte Strøm from Sharpen. I'm very grateful for their contributions to this work. So what is actually the problem that we have identified? The problem is that there has been a long series of RCTs over 40 years of research. This has included randomization of a large number of individuals, mostly children, more than 90,000. But when we look at what the results are, then virtually all of those that are claimed to be findings are not real, and the power to identify any effect in these studies is as low as 7%, at least that's what we estimate it to be. And note that the 7% is very close to the false positive error rate of 5%. We'll talk more about that later. So there has been a lot of debate since we started looking into this, and perhaps it's useful to start with things that we might agree on. And I think it's safe to say that we just love randomized controlled trials, and that include Christine Stabel-Ben. Here I found a quote, but I could have found many more. We think that it's important to have randomized controlled trials to establish the evidence, and I couldn't agree more. So what we possibly disagree on is how to evaluate the evidence then. So let's try to look at what you could call the primary endpoint, and I've interpreted that as the first mentioned estimate for any trial reporting. And Christina has published a different way of counting, where she says that there are 13 separate trials and vaccines. They have found effect apparently in 5, and there were 2 that had an effect on the predefined secondary outcome, and then there were no effect in 6 of them. But if we only count one primary endpoint per trial, then the counting is that there is one trial which had such a finding, and then we can discuss how many trials we want to include, but none of them have any primary findings. So at best, it's 1 in 13. I would say it's probably more realistic to say 1 in 17, or we could even go higher if we wanted to include more trials. So the one trial that did show an effect in the sense that it had a significant primary endpoint is this one from just last year, published last year by Sanne Marie Thyssen as first author. It was a study that was actually failed because it couldn't include more than a third of the intended participants. So this should be viewed with some skepticism as pertains to how it can actually confirm any hypothesis. There is another trial that was not published so far. There is just a preprint out. This is a trial that was concluded in 2012. And in this trial of the DTP booster vaccine, the results were negative. Not only were they negative, but they actually pointed in the opposite direction of what was pre-specified as the hypothesis. So if we sum up what we could possibly agree on, I think it's fair to say that there is one trial that has not yet been really published. It's in preprint. There are more than 14 trials that have been conducted with vaccines. There are more than 90,000 individuals randomized, and except for a single failed trial, no single trial has actually had statistically significant primary endpoints, which we find is a problem. You want to do studies that are able to show effects. So with this in mind, let's take a look at how do you actually count evidence from randomized controlled trials. So here is a textbook, which I think is quite informative about this. It represents, at least to me, the standard way of counting. I have not been able to find other ways of counting primary outcomes. So in the summary, the conclusion of this book on how to report these studies, it's specifically pointed out that there can only be one primary endpoint. And if you don't have that, then you should use some way of controlling the type 1 error rate or the false positive error rate, and you should divide your significance level so that the overall error rate is maintained. You should do this by declaring it in advance, and you cannot, after you've done the study, select the one outcome or endpoint that you think looks the best. And then they provide a typical example. The example says that if you have hospitalization as your primary endpoint and the p-value is 0.08%, well, that means it didn't show an effect on the primary endpoint. But there are secondary endpoints, and they actually had statistically significant effects, impressive reductions in mortality rate, and a p-value that was quite low. And then comes the conclusion on this example. There is only one acceptable interpretation of the above example. The study results are negative. Full stop. And further, the p-value has meaning only for the primary endpoint. And this means that I would argue we need to count in the way we have done. That is, we count one primary endpoint for each trial. So now let's take a step back and look at what we do in randomized controlled trials and why we really appreciate the evidence that is coming from these randomized controlled trials. So first of all, I think most of us will know that it's at the top of the evidence hierarchy, and that's because it's actually very useful in controlling the various biases, both those that we can understand and observe, and also those that are simply unobservable. And so randomized controlled trials may be difficult to do. They may be not always be feasible, but in any situation where they are, it's really great to be able to do these. And I think they are a very vital and very important part of any triangulation of evidence. So what is the rationale that we do exploit in this randomized controlled trial? Well, the strategy of an RCT is that we want to pre-specify an hypothesis, and then we want to falsify that. And the hypothesis that we would like to falsify is that the effect does not exist, because then we may be able to conclude that there is an effect from our whatever intervention we are studying. And the point here is that it's up to the investigators to design the study in such a way that the study will deliver convincing evidence that this null hypothesis of no effect is false. So the purpose of doing an RCT is not to find evidence that might support an effect. We want to reject the hypothesis that there is no effect. So the way we do this is that RCTs are also part of a scientific wheel, you could say, where we have good ideas, and from these ideas we generate a research question that we outline how we want to study. Then we specify what data we would like to collect, and we do that. Then we look at the results of those data, and then we can take another spin of the wheel here. And the idea is that any single trial may not show definitive answers, but it's part of a larger process. And that larger process is valid because we are playing all these individual trials according to a standard set of rules. For randomized controlled trials, those rules are known as the consort rules. So what they specify is that beforehand, before the investigators begin the trial, they have to sort of put forward how their hypothesis, if true, will generate a slam dunk in this randomized trial. They need to have a very high probability of being able to find the effect that they are looking for. Typically, we require 80 or 90% power. That means that you, in a sort of way, wins 4 in 5 at least, or even more, 9 in 10. And that is if only your hypothesis is correct. If your hypothesis is wrong, well, then it's a literal spin of the lottery wheel, and you win 1 in 20. You have a 5% chance of having a significant effect. And that the point here is that any particular trial is subject to error. So it may not show an effect even though the effect is there, or it may show an effect even though there is no real effect. And that's just to handle this, we have this standard set of rules for making decisions about what the study shows. How do we then conduct the RCT? Well, you can think of it this way, that we have a trial, and what we add into this trial are two sort of active ingredients. We add randomization and we add an intervention. And the randomization means that it's random who gets the intervention. But actually, you can also think of it in this way, that we add some random noise that we know how behaves in order for us to see how the systematic effects behave. And this random thing that we add is sort of like a contrast liquid that can be used to identify the effects of the intervention. Then there are a lot of things we do to remove effects or remove bias. We use blinding, we use validated measures, we are very meticulous in our follow-up and all sorts of things. But that's more to avoid having bias from other sources. So the two active ingredients in an RCT is that we add randomization. Remember that. So the randomization part will actually create some random study findings 5% of the time. So if we were to do 100 studies and we just had placebo in both arms, then we would in 5 of those studies on average see that it had a significant primary outcome. On the other hand, if our pre-specified hypotheses as investigators were correct, then we would see that 80 or 90% of the time we would have a real finding of an effect. We would have a p-value below 5%. So the plus here means that we have a significant finding on the primary endpoint. A 0 or O means that we do not have statistical significance on the primary endpoint. Now, the problem in an RCT is, of course, that we don't know what the effect of our intervention is. So that's why we do the RCT. This is exactly what we want to figure out. But we do know that what we have added in terms of random noise, the blue ones here, behaves in a very pre-specified way. So we've done a trial. We have a primary outcome. We have a p below 5%. And now, what does it mean? We have a plus as our primary finding. Is it a red plus, meaning that it's a real effect? Or is it a blue plus? That is, it could be a random effect. How do we know? Well, the point is, of course, that in any particular study, we don't know. But we have a standard procedure, a consistent procedure to decide things. So we call this a plus for any particular trial, knowing that we may say that we now claim that it's a finding, even though it may come from the null distribution of random findings. Similarly, we also have the result of not having a significant primary outcome. And again, we need to decide, is this then a failure of the study to identify a real effect? Or is it actually a red result we have here? Or is it blue? Is it just because chance? It was a random finding, as it should be, because the effect was not real. And so what we're looking at is something from the blue distribution, the null distribution. So whatever we get as our finding from the study on our primary endpoint, we need to decide whether we believe it's a real effect, a red effect, or whether it's a random occurrence, a blue effect. And that's true whether we have a plus or a 0 from our trial. The point is that once we do this in repeated trials, then if we have a consistent decision rule, we'll eventually arrive at solid conclusions. So in any given trial, we may have a finding that is not significant, but if we have more trials together, then eventually they will show what the real effect is. This idea of how to do replicable trials, as mentioned, as stated in the consult rules, are exactly the rules that Christine Stabel-Benn and Peter Åby chose to play by, as they have registered in their protocols. This is the ICMJE you see here in one of their protocols. And what is also mentioned in the consult statement is that you should be particularly concerned with the risk of multiple comparisons. You need to be aware that if you start having multiple time points, multiple outcome measures, multiple subgroups, then your risk of false positives increase, and you need to control that risk. So how do this group from the Bandim Health Project then do inference? So one of the first things I looked at for the Weekendavisen was this PhD thesis, which is 15 years old almost. And in this PhD thesis, I found a long list of main findings. I'm sure you can't read them. I just wanted to show that there are several. And also a conclusion that says that these findings supports that there are sex differential effects of DTP. But if you look at sort of the totality of the results in this thesis, you find that there are very, very many estimates reported. 371, if you leave out those that just compare the two sexes, then it's 350, organized neatly in tables and figures. And once you look at how many of those are actually statistically significant, the surprising thing is that you get very, very close to 5%. So I believe any conclusion here would be that this is compatible with random noise. There aren't really any effects in this PhD thesis. And this could be explained by this being a part of a larger trial. So this is just a third of the trial, and these are all secondary outcomes. There was a publication made based on this PhD thesis. It's this one from 2011, I believe. And these are the main results. Again, there are many, and I'm not anticipating you can read all of them, but note that there are a list of interaction tests, p-values for interactions, and 2 of them are statistically significant, and those are exactly the ones that end up as the main results in the abstract. And it's also what is then concluded in the conclusion. So the 2 interaction effects that are statistically significant are interpreted as being findings that are real and show something about DTP and sex. Now, the real story of this trial is that what we have seen so far are just secondary outcomes. The primary outcome was mortality. And there was a pre-specified hypothesis, which I have here switched. It was 0.66, but I have switched it around. So it's that DTP booster vaccine, when you receive that, you have a 50% higher mortality among children. But the results that have just been published in a preprint shows that actually there was a 14% decrease in mortality. It was not statistically significant, but it's in the opposite direction of what was anticipated by the investigators here. And it also has a confidence interval that does not include the pre-specified hypothesis. Another example of how things are concluded in this research is this one, which also reports secondary findings. And here it said that we see an effect of early measles vaccines, especially among girls in the dry season. That's one group. And the other group where we see this effect is those who received a placebo vitamin A. And that's just a strange result. Does that mean that you need to receive a placebo treatment in order to see an effect of measles vaccine? Again, I think this is driven by a hunt for significant p-values. Then there is another example here, which is this time on the BCG vaccine. That's the vaccine for tuberculosis. And this is a series of trials. In the first two trials, the main results were on child mortality in infancy, that is before in the first year of life. And both of these trials had insignificant primary outcomes, as you can see here. These two trials were then used as motivating a third trial. And in the third trial, in the introduction, it says that these non-specific effects have recently been confirmed, which is a bit strange since we had insignificant findings in the first two trials. But leave that aside. Those two trials had secondary outcomes, which were included neonatal mortality. And so this was used to make a new power calculation for a third trial, which then wanted to confirm an effect on neonatal mortality, and it was pre-specified in the power calculation that there should be a 45% reduction in neonatal mortality. That's almost halving of the mortality from all causes, not just measles, but all causes, neonatal. And what then comes out of the third trial is that it's unable to demonstrate this effect. It had non-significant finding on the primary outcome, neonatal mortality, as you can tell from this confidence interval here. But then a meta-analysis that was not in the protocol is added, and suggesting that if you add all three studies together, then you see marked reductions in mortality in a range of time periods. So I think this is strange because there is a switch of outcome here. Are the two first trials just sort of interim analyses? And if so, shouldn't that be controlled for then when you do the final analysis? And can you really think of these three sub-trials as just being independent trials that can be used in a meta-analysis? Wouldn't that need to include studies from other places and other research groups? And basically, I'm just in doubt whether this is one trial, three trials, or four trials. And I think this is all something that leads us to consider how you can inflate the risk of false positives in an RCT. So you can start modifying the primary analysis, you can promote a secondary analysis, you can look for general trends, you can look at subgroups, whatever, or you can keep repeating your study until you find the correct, whatever you think is correct direction of effect. And this is really known as data dredging or p-hacking. And to show what kind of extreme, or you could even say perverse results you can get with this strategy, some researchers bought a dead salmon and looked at how its brain would respond to some stimuli. And they did brain scans. And they actually showed that there were signals, because these signals consisted of very, very many p-values, or in this case t values, but it's equivalent thing. So if you only have tests enough, you can find an effect, sure, but it's not meaningful. A specific version of the problem with p-hacking is what is known as the garden of forking paths. So imagine an analysis. You have to make decisions about who to include, who to exclude. How do you assign various things? How do you censor? How do you choose to adjust and so forth? And all of those can be sort of viewed as a path that splits the way, it's forks in the path. And then wherever you end up, you cannot just pretend that your result is the only possible result that is compatible with the data you started with. You will have a range of very different results. And somehow, if you just do this naively, you may end up somewhere that has very little relation with what the original data showed. And the way to deal with this statistical crisis in science created by a garden of forking paths, the way to deal with this is to have a pre-specified analysis plan. So this is what you should do, and you should pre-register it, and you should follow it closely. So there is a particular way also where you can try to not control your type 1 error rate or false positive rate, and that is that you create your own inference rules, also known as a paradigm. And actually, Peter Åby and Christina Stable-Benn has suggested a new way of analyzing or considering evidence. So they have presented this figure to illustrate how they want to do this. And I guess my main question is, how do you confirm a hypothesis if not by looking at a pre-registered hypothesis, a pre-registered study with a pre-registered protocol, and then you just look at what the results are? And I just fail to see how any of their randomized trials have been able to confirm a hypothesis, let alone confirm it twice, as apparently is the critical thing according to this new paradigm. So what are then the findings that have been claimed in terms of non-specific vaccine effects? So it's not only that they exist, but it's also that they have some various patterns of effects. So we have the live vaccine that have beneficial NSEs, or dead vaccines that have harmful NSEs, and so forth. Or we have that it's sex differential and so forth. But if you look closer at all of these different principles of NSEs, you can see that they are all some version of an interaction effect. And that's a bit peculiar, because when you see studies that don't have power to identify main effects on the primary outcome, it's very surprising if they should be able to identify any interaction effects. Because if you want to study a main effect and have 80% power for that, then you need to have a study which is 16 times larger than that if you want to study just a single interaction effect. So it's very, very unlikely that these studies should be able to have any evidence on interaction effects or give any support to any interaction effects. So in April, when we had a discussion about the primary outcomes, it soon became evident that it would be useful to also know more about what the secondary outcomes showed. And so I suggested that we did a review of the secondary outcomes, and I found a group of co-authors willing to work on this. And then we included papers on the DTP, BCG, and measles vaccine from the Bandim Health Project. And we found 40 papers, but could only include 26 because they had a pre-registration, they had a pre-specified hypothesis, and they were comparing the randomized groups. So here are the 26 papers that we were able to identify. And I've just made a quick scoring of them here. So you see that there is one study which having a positive primary finding, a p-value of less than 5%, as we've shown earlier. And then the 25 papers did not have that, so they're marked with an O. And then there are 2 papers in 2016 which used control for multiple testing, or correction for multiple testing. And they are preceded by a series of trials before that, and they have trials after that as well. So do we need to correct for multiple testing? You could say if you only have one primary outcome and that's what you report, no. But if you have multiple, then sure, because once you start having, for example, 25 secondary outcomes, there is a much larger seed that you can sort of fish your findings out from. And if you have 100 outcomes, of course, there will be many more. So if you start to have many secondary outcomes, then you'll have a long sequence of positive and negative findings, but you will sort of be overwhelmed by findings that are from your null distribution, the blue distribution of your study. So does the random variation in a randomized controlled trial matter? Yes. Here is a simulation I've done of 100,000 p-values. They are, as they should be, uniformly distributed, but note that there is actually still some variation in different areas of this distribution where you see that there are more p-values than you would expect. So here I have more small ones than I would expect, and then I have slightly less in the subsequent interval and so forth. But it just shows that random variation is actually a thing. It matters, and that's what we add when we do randomized controlled trials. So what we then did was that we took the 26 papers, we looked at all the reported estimates and p-values and converted them into so-called Q-values or set transforms. And we've ranked them according to their size, that's the x-axis, and then we look at the probability on the y-axis. So it means that there are those who had the smallest p-values / Q-values are down here, and then once we get to larger values, we see that there is a uniform distribution here, which are clearly those p-values that come from our null distribution, the blue ones. Then there is a bump here, which is a bit strange, and that sort of corresponds to blue p-values that were almost significant and then promoted. So you could say this is cherry picking of blue p-values to bring them closer to being significant. We also did another type of analysis where we did a Holm-Bonferroni correction to the results. We didn't do it to each trial, which we probably should have done, but we were a bit more mild. So what we did was that we took each table or figure from the published papers, and then for those individual tables or figures, we did a correction. So this is milder than what you ideally should be, but that's because you may have positive correlation of outcomes. What we find is that only 1 in 25 papers actually had a secondary finding that survived multiple correction. But yet in 23 of 25 papers with secondary outcomes from trials with negative primary outcomes, there was a claim that these secondary outcomes supported a non-specific effect. I would also like to add that there has been a question about whether we have included a bit too many estimates. We have found one table 1 that should not have entered, but since all of these corrections are per table in this analysis, it doesn't matter. And so we stand by this analysis. This is actually the finding we have. And based on that, I would argue that our conclusion has to be that sure, absence of evidence of effect is not evidence of absence of effect. That is true, but we should remember that it is actually an absence of evidence.